When cellular stress exceeds a cell's ability to adapt, it enters a state of injury. For a time, this swelling is reversible, but once the outer membrane ruptures, the cell reaches the point of no return. This is necrosis. Cell death follows two distinct paths. Apoptosis is a regulated, programmed suicide that allows for clean removal without an inflammatory response. Necrosis is unregulated death from injury, which universally triggers acute inflammation. The most frequent instigator of this process is ischemia, reduced blood flow to the tissue. This triggers hypoxia, the depletion of oxygen that kicks off a deadly biochemical cascade. This flowchart traces the initial failure. Hypoxia forces a drop in ATP production, causing the Na/K+ pump to fail. Sodium and water then flood the cell, resulting in the characteristic swelling of reversible injury. Moving down the flowchart, the cell shifts to anaerobic glycolysis. This produces lactic acid, which lowers the intracellular pH and creates an increasingly acidic environment. The transition to irreversible necrosis is marked by a massive, unchecked influx of calcium. This calcium acts as a trigger, improperly activating four destructive enzymes. Nucleases shred DNA, lipases destroy membrane lipids, proteases dismantle the cytoskeleton, and ATPases accelerate the depletion of energy stores. The loss of oxygen leads to a total biochemical collapse. The cell actively dismantles its own structures as a direct consequence of this failure. Pathologists identify this collapse through specific microscopic changes. Under an H&E stain, the cytoplasm becomes intensely eosinophilic, turning a glassy pink, as structural proteins denature and intracellular RNA is lost. Nuclear degradation follows a three-stage sequence. First, the nucleus shrinks and darkens as the chromatin condenses. This is pignosis. Second, the condensed nucleus fragments into smaller pieces, a process called karyorhexis. Finally, in karyolysis, nucleases dissolve these fragments completely. The nucleus fades from view, leaving behind only the outer silhouette of a ghost cell. This diagram illustrates the two ways this dead tissue is cleared. Autolysis is self-digestion by the cell's own lysosomal enzymes, while heterolysis is digestion by external neutrophils and macrophages. At the ultrastructural level, electron microscopy reveals the final proof of death. The bottom left diagram shows myelin figures, whorls of phospholipid from damaged membranes, and dense amorphous accumulations within the mitochondria. As membranes rupture, intracellular enzymes leak into the blood. These enzymes, such as troponin, serve as clinical markers that allow physicians to diagnose specific organ damage. Irreversible injury leaves distinct signatures at every scale, allowing for a definitive diagnosis long after the initial biochemical event. The macroscopic appearance of necrotic tissue is determined by the balance between two processes, the denaturation of structural proteins and enzymatic digestion. In coagulative necrosis, rapid acidification denatures proteins so quickly that the cell's basic architecture is preserved. The tissue stiffens, locking its physical shape in place. Because the enzymes meant to digest the cell are also denatured by the low pH, the ghost cell outlines remain intact for several days. This is the default pattern for all ischemic solid organs, such as the heart, kidneys, and spleen. Liquefactive necrosis represents the opposite end of the spectrum, where enzymatic digestion is so aggressive that it completely obliterates the tissue architecture. This typically occurs in bacterial or fungal infections, where neutrophils release a massive volume of enzymes to destroy the pathogens, turning the surrounding tissue into liquid pus. There is one major clinical exception: brain infarcts. Because the brain is rich in enzymes and lacks a dense structural stroma, ischemia in the brain leads to liquefactive necrosis, not coagulative. The final appearance of the dead tissue depends entirely on whether the local environment favors freezing the architecture or digesting it. Caseous necrosis is a hybrid pattern with both coagulative and liquefactive features. It is characterized by a white cottage cheese macroscopic appearance. As shown in this diagram, caseous necrosis occurs when the immune system attempts to wall off resilient organisms. This creates a granuloma, where necrotic debris is surrounded by a collar of lymphocytes and macrophages. Caseous necrosis is the hallmark of tuberculosis and systemic fungal infections. Fat necrosis involves the enzymatic destruction of adipose tissue. It is most commonly seen in acute pancreatitis, where leaked lipases break down the fat surrounding the pancreas. These lipases break down fat into fatty acids, which then bind with calcium to form chalky white deposits. While this enzymatic process is common in the pancreas, the same white deposits can also form non-enzymatically in breast tissue following physical trauma. Fibrinoid necrosis is a specific form of death localized to blood vessel walls. In cases of vasculitis or malignant hypertension, immune complexes or extreme pressure force fibrin into the vessel walls. This creates a thick, bright pink appearance on histological slides. These highly recognizable patterns act as a map, allowing pathologists to trace the tissue death back to the underlying disease. Gangrene is a clinical term for bulk macroscopic tissue death, usually involving a limb or the intestines. It is a progression of the necrotic mechanisms we've discussed. Dry gangrene is a purely ischemic event. It results strictly in coagulative necrosis, which produces the black, mummified appearance seen in the extremities of diabetic patients. If that ischemic tissue becomes infected by bacteria, it is classified as wet gangrene. The arrival of neutrophils brings destructive enzymes that superimpose liquefactive necrosis over the existing coagulative necrosis. Gas gangrene is a specific, dangerous infection by Clostridium perfringens. The bacteria release exotoxins that destroy tissue and produce gas bubbles, creating a crackling sensation called crepitus. Gangrene represents a clinical emergency, where simple ischemia often creates the environment for secondary bacterial destruction. For the board exam, these mechanisms must be consolidated into a reliable diagnostic framework. This master matrix summarizes the rules. The primary question is whether tissue architecture is preserved. Coagulative necrosis preserves scaffolding via denaturation, while liquefactive destroys it via digestion. High-yield exceptions. Brain ischemia results in liquefactive necrosis, and fat necrosis triggers saponification, leading to hypocalcemia. This comparative matrix provides the algorithmic logic required to interpret tissue death on board exams. Case 1. A 65-year-old with a myocardial infarction shows ghost cells. The diagnosis? Coagulative necrosis. Case 2. A stroke results in a large brain cavity. The diagnosis? Liquefactive necrosis. Case 3. A chronic cough with caseating granulomas. The diagnosis? Caseous necrosis from TB. Case 4. A patient has epigastric pain and hypocalcemia. Diagnosis? Enzymatic fat necrosis from pancreatitis. Case 5. A hard breast lump found after trauma. The diagnosis? Traumatic fat necrosis. Case 6. A toe is black and mummified without infection. The diagnosis? Dry gangrene. Case 7. A diabetic toe that is swollen and purulent. The diagnosis? Wet gangrene. Case 8. A leg injury presents with gas bubbles under the skin. Diagnosis? Gas gangrene. Case 9. A lupus patient shows bright pink renal vessel walls. The diagnosis? Fibrinoid necrosis. Case 10. Electron microscopy shows myelin figures and calcium in the mitochondria. The state? Irreversible cell injury. Case 11. Why does elevated troponin confirm cell death? Because intracellular enzymes leak after membrane rupture. Case 12. Identify the first irreversible nuclear change visible on histology. The answer is pycnosis. Case 13. A liver sample digests itself in a sterile environment without inflammation. The mechanism? Autolysis. Case 14. A cell displays membrane blobs with a normal nucleus. This is reversible injury. Case 15. Extreme malignant hypertension causes vessel wall damage. The diagnosis is fibrinoid necrosis. By accurately matching these distinct architectural patterns to their specific biochemical failures, pathologists determine the exact cause of death.